Organizing this TRAC program. The topic to be discussed now is first new generation insulins, scientific breakthrough beyond human insulins. As we know by speaker Dr. Suresh Prabhu, analog insulins, but efficacy wise both analog and human insulins are same, but the difference lies in the lesser incidence of hypoglycemia and better safety and better flexibility in timing and dosing. In current clinical practice, even though the analog insulins, their usage is increased, but still lot of patients are still using only human insulin, probably because of cost factor, especially among poor and middle class, who form the majority of our diabetic population. So with this introduction, over to the speaker.
Thank you. At the outset, I thank the organizing team of this chapter and also respected chairpersons. And the next 15 minutes, I'll be discussing about the newer insulins. It's not newer, they are already there for almost 10 years. This is my financial disclosure. So as our chairperson explained, almost 100 years back, we know that when the insulin was discovered, we have to give at least 5 to 6 times per person, and then we need to have a glycemic control. But for every 2 to 3 decades, we have a shift or paradigm shift in terms of the glycemic control and insulin discovery. So in 1936, the NPH was introduced. We know that NPH is a neutral protamine hexagon, which makes the insulin as a long-acting. And then in 1950s, we have a pure or monocomponent form of animal insulin was introduced. And then in 1980s, the human insulin has been included. And after that, we have what we call it as a second generation designer form of insulin, where we have ultra short acting and also long acting insulin. I still remember during my college days in 1990s, we used to have the animal insulin, and there is a sudden shift in the government policy to procure human insulin. So animal insulin, they fare well, but they have higher immunogenicity, and because they are sourced from animal, it has limited availability and it has some impurities. In some patients, we have seen autoimmunity and also the hypertrophy that happens in our patients. So as in 1980s and 90s, the human insulin has been introduced. We found the production of this insulin can be scaled enormously because of the recombinant technology, and they have lesser immunogenicity. The conventional insulin, we know that we have 3 types of insulin. One, the short acting, the intermediate acting, and the premixed insulin. The premixed insulin is, as the discussion happened later, like the metformin and the voglibose, it is for convenience. It's not physiological, it's pure convenience. We use this insulin, but it is the most commonly used insulin in our clinical practice. The conventional insulin, as the chairperson has mentioned, it has its own inconvenience, even though they are human insulin, because after getting injected in the subcutaneous tissue, they causes the hexamer formation, and then the peak is not related to the peak of the glycemic control. The peak happens almost a hour or at the time of the glucose peak, around 2 to 3 hours the peak happens. So that what happens, the insulin will be there when the glucose is started going down, and we get a hypoglycemia probably 3 to 4 hours after giving that insulin. So I still remember when I was doing my the post-graduation and super specialty, the first thing we write in the patient thing will be the 3 meal and 3 snack pattern. So in the meal means we have to give 3 meal and 3 snack to overcome the hypoglycemia that happens with this form of insulin. You remember insulin 30-70 given at night 8 o'clock or 9 o'clock, it peaks at around 3 o'clock, and then it causes hypoglycemia. So we need to bring down the hypoglycemia to give a late night snack in our patient. And there are certain changes. One thing, we need to change the lifestyle according to the insulin. So we have to carry the insulin. We need to change the diet pattern, and also we should concern about hyperglycemia. And every time after injecting, we have to wait for 20 to 30 minutes before having our meal. So this restricts our activity. When you go for a marriage, we have to wait and then inject and then go and wait, so we cannot have it. When we take that one, that actually changes the glycemic variability in our patients. So my agenda will be, I'll be discussing about two newer insulins, one the IDEC ASP, and second will be the long-acting second generation Tresiba. So this is a conventional patient what we come across in your clinical practice. It's a 54-year-old patient, BMI of 24, diabetes for 11 years, on 3 drugs and a premixed insulin. In spite of that, this patient HbA1c is 10.3, postprandial is very high, 286, fasting is also high, frequent episodes of hyperglycemia, and lack of quality of life. So how to approach this patient? So what is the co-formulations available? We have 3 co-formulations, one low mix and high risk. Low mix will be 25 or 30-70, or high mix will be 50-50. So we have both basic insulin, which is mixed start, biphasic analog insulin, the Novomix and Humalog mix, and also the degludec aspart. So degludec aspart is I'm going to discuss. The degludec component is a long-acting component. It acts more than 24 hours, and the soluble part of insulin act for a shorter duration of action. The conventional insulin has its own, premixed insulin has its own limitation. Because of the absorption, it has variable glycemic control. We need to resuspend, and it has a shoulder effect. That's what I mentioned. When the peak of the one insulin happens, the peak of the other insulin also happens, leading to the shoulder effect that causes hyperglycemia prior to the meal. So that is more common with this premixed insulin. So what is the ultra long acting co-formulation, the IDEC ASP or Rysodec? So the Rysodec contains 2 separate molecules of insulin. One is degludec 70% and short acting insulin 30%. The IDEC degludec is present in the dihexamer. 2 hexamers are attached, and the short acting aspart is present as a monohexamer. So what happens when we inject into the subcutaneous tissue? The IDEC hexamer and the IDEC aspart is actually separated, and because the subcutaneous tissues, the aspart actually immediately dissolves as it enters into the circulation, and because the IDEC dimers have a single side chain, it forms a long multi-hexamer, and it releases slowly because of the resorption of the phenol. So there are several studies has been done, a non-inferiority study, and the common is switch 1 and switch 2 trial done in type 1 and type 2 diabetes patient. In that, the outcome is they are not inferior to the glargine U100, and also they have increased safety things in terms of hypoglycemia, particularly nocturnal hyperglycemia in our patients. So even though the glycemic controls are almost same, but it is better in terms of hypoglycemia in our patient. And this is from switch from the older premixed insulin to Rysodec. This was published in 2014, and if you see patients who are on premixed insulin, when they convert to Rysodec, what happens? It's the HbA1c after 6 months from 7.8, a further reduction to 7.1, which is statistically significant. Fasting blood sugar of 7.9 to 6.9 millimoles per liter, it is statistically significant, and postprandial from 10.3 to 8.9. So all the 3 parameters are better after changing on from the premixed insulin to Rysodec. And if you see, the dosage also reduced after 6 months from 5.7 unit per kg, the dosage have come down to 0.49 unit per kg, which is also statistically significant. So this the dose reduction in degludec component of Rysodec, in this trial they have given the degludec and the aspart as a separately. So what has they found? The dose at 3 months and dose at 6 months, there is a reduction in the dosage of degludec component by 21%, and after 6 months the degludec component has reduced by 19%. So on the safety profile, as we already discussed, there is a 54% reduction in the confirmed hyperglycemia, and also 75% reduction in the nocturnal hyperglycemia compared to the biphasic aspart 30. So this is very much important when a patient, elderly patient who have higher risk of hyperglycemia, or patient who have other risk factors like cardiovascular disease, when the hyperglycemia is important, there is almost more than 50% reduction in the hyperglycemia that happens with this combination. So switch from Ryzodec to older premix insulin have improved the efficacy in terms of glycemic control, lower dosal requirement, lower injection frequency, and also improved safety. That's what I feel is more important in our patients, in our high risk patients. So move on to the second case scenario. I have another 4 minutes. This is a 54-year-old patient, businessman, BMI of 24, type 2 diabetes mellitus of 11 years, 3 drugs and Ryzodec of 10 unit. This patient, the first patient what we see, the HbA1c was achieved without hyperglycemic episode, and patient have a very good quality of life. So moving on to the second case. This is our second patient, Ramesh, 55-year-old, teacher by occupation, BMI of 23, diabetes for 7 years, fasting of 182, postprandial of 208, HbA1c of 9.8. Patient is on 3 drugs including pioglitazone and a basal insulin of NPH, faces difficulty in injecting insulin at fixed time of day, and CGM report shows high variability. So problem with the NPH insulin is, even though they are long acting insulin, they still have a peak at around 6 to 8 hours, and then it lasts for around 12 hours. So that causes increased risk of hyperglycemia in those type of patient. We know that basal insulin are the preferred insulin at the onset of insulin initiation in our patients. Almost all of them, the guidelines have recommended the basal insulin. Ideal basal insulin should have a flat glycemic profile, long duration of action, minimal variability, and low risk of hyperglycemia. So this is what the parts of the NPH insulin. The initial NPH insulin have half-life of 5 to 10, and then the first generation U100 glargine have half-life of 12 to 19, and then the second generation insulin have a duration of 25. So the unmet needs with conventional first generation analog insulin, they are not truly 24 hours, sometimes it lasts only for 22 hours. They have a higher variability, fixed time dosing, it has to be given at the specific time, and not truly peakless. So this is the action profile of the Tresiba. And then if you see the glargine, even though they don't have, they are long acting, they still peaks at certain time of the day to causes sometimes hyperglycemia in our patient. And the precipitation is the way how glargine acts, because of the pH difference between the insulin, which is 4 pH, compared to the neutral pH of the subcutaneous tissue, it gets precipitated and then it gets dissolved slowly and enters into circulation. If there is any change in the pH of the patients, like in patient with sick patient, there may be some difference in the absorption of this drug. And this is the efficacy of Tresiba versus glargine U100. The Switch Pro trial is a latest trial in terms of the comparison of the glargine with the Tresiba, and they have included the CGMS in this trial, and they found that patient in the Switch Pro trial have a better outcome in terms of the glycemic control in that trial. Several trial, the once long flex, low volume T1 flex and switch trial done in both type 1 and type 2 diabetes patients have clearly shown that apart from reducing the nocturnal hyperglycemia, there is a better fasting glycemic control in Tresiba compared to that of the glargine U100. So this is Switch Pro what I discussed. This patient, when a CGMS was done, the estimated time in range was slightly higher in the Tresiba group of around 20.6 minutes per day in favor of the Tresiba over glargine. So more number of patients have attained the glycemic control within the time in range in patient who on Tresiba compared to the glargine. And the Tresiba overall trial, this is include not only that trial, overall the real world study and other trial have shown that it is better in terms of hypoglycemia. The overall hypoglycemia is reduced by 30% in the switch to severe hypoglycemia by 51% and nocturnal hypoglycemia by 53%. So consistent proven hypoglycemic benefit with Tresiba has been shown, and then it has a dosing flexibility. Even when we miss the morning dose of Tresiba, we can give it in the afternoon, sometimes in the evening also we can give, because of its very long duration of action. And it is approved in almost all the conditions like pediatric, adults, renal, elderly and hospitalized patient. And when we start, we can switch over from the naive GLP-1 receptor agonist to Tresiba at 10 units recommended as initial dosage. When the patient is already on basal insulin, we can convert to 1:1 basal component, to the premix, we can 1:1 we can convert, and the patient is on glargine or basal BID, we can reduce the dosage by 20